Good morning. It's very nice to be here with you guys today. I am a primary care physician and a health system leader, and I, as you just heard, spend a lot of time thinking about the quadruple aim. It's something that's on the top of a lot of our minds. How do we actually seek better population health outcomes through more effective interventions? How do we prevent more illness? How do we decrease disparities? How do we improve the experience of care for our patients, measured by better quality, better satisfaction, more trust? How do we actually improve the way in which we're allocating resources within the walls of our systems through lower per-person costs? Can we decrease per person costs and improve appropriate spending? And finally, as you just heard, I think a lot out of self-interest about joy at work for those healthcare professionals who are trying to achieve those other three aims. I measure those in a number of different ways. We can look at professional recruitment and retention rates. We can look at job satisfaction. I tend to ask my team about how many happy dances they've done in the past week. Have you seen a happy dance at work recently? Kind of looks like this. It may vary across the country. There's some variability studies happening right now, but the point is the quadruple aim is top of mind for all of us. And I also think that it's important for me personally, and I think increasingly for all of us as we look at the costs of care, the costs of health care in the nation, where $1 in $5 or more is going towards our work and not towards more parks and schools or transportation. When we accept the responsibility, the fiduciary responsibility that comes with that allocation, we have to ask ourselves about how the achievement of the quadruple aim itself bears on greater society. What does the quadruple aim look like against the backdrop, as you see there, of equity, of whether or not we're increasing opportunity? Are we providing more spaces for shared decision-making, not just within the walls of our clinics, but in the community as well? These and more questions are all the ones that I think everybody in this room think a lot about. I tend to think a lot about it within the work I'm doing right now, and have been doing so for the past 12 years of my career. It's a lot. Each aim unto itself is difficult, but once you put them all together, it's even more challenging, and then you think about equity, and my God, it's like a whole different challenge. So to understand this challenge, we can talk about policy, but I think it's better to talk about a person. And the person I want to tell you about is a gentleman named Mr. Urias Martin. I met Mr. Martin 2 years ago while working in a hospital in Los Angeles. We met in a small room, a little smaller than this, within a large emergency department in a busy hospital. Now, to understand Mr. Martin, you have to understand that he charts his life course back to a very momentous occasion, to November 18th, 1974, when he signed up for the military, the Army. That same month, just to give you a sense of context, John Lennon gave his last performance at Madison Square Garden. President Gerald Ford had just signed the SALT II Treaty to reduce nuclear weapons, a compact with the USSR, remember that? And Mr. Martin charted his course by entering the military, and he, as he told me when we first met, had become accustomed to a life of work. A few years before I met him in that emergency department, something happened. Mr. Martin passed out on the job. A coworker of his called the paramedics, and they rushed him to the hospital, where he was found to be that close to a diabetic coma. It was a wake-up call for him. But it's not that complicated to understand what had happened. You see, in Mr. Martin's life, at that point, he was struggling to make ends meet. Putting food on the table was a challenge. He was suffering through some bouts of depression. Some relationships in his family were getting frayed. And as it became harder and harder to balance all of those struggles in his life, he ended up losing his job. He spent time couch surfing, doubling up with friends and family. Eventually, he ended up living on the streets in his van. And so for him, his priorities on the Maslow's hierarchy became food and shelter. And not unlike many individuals in the country who faced those challenges, he found that he could get a hot and a cot in the local emergency department. And so he went again and again to one of the emergency departments in Los Angeles, and that's where we met. When we met now, my care team and I, again, we're thinking about the quadruple aim. We're thinking about how we can, for Mr. Martin, improve his outcomes, how we can make sure we're doing so at lower cost, how we can make sure we're improving the quality of care and better outcomes while also having the happy dance. It was challenging. It was hard to get him to his mental health provider when transportation was an issue. It was hard to actually make sure that he was taking his medications on time when he couldn't find a place to store it. Our care team was committed, just like a lot of healthcare professionals out there. Our care team put in place what you'd expect these days. We put in place systems and tools to better communicate with each other. We actually went so far as to sharing the same 10-foot by 10-foot room. That's a doctor, a licensed vocational nurse, a clerk, and a social worker, all in a 10 by 10-foot room. We were huddling incessantly. And we went and we huddled with patients at the end of every visit, including Mr. Martin, who had a complicated history. And what we found was that while we were making some headway, the only way to truly make things matter for Mr. Martin and to achieve for us some joy at work, let alone the quadruple aim, was by more actively listening and screening for the issues that really mattered for him. It turns out that Mr. Martin had, at least at that point, 5 jaywalking and traffic citations from walking the streets of Los Angeles without being housed. That apparently is an offense. He couldn't pay the fines for those citations, and so those stacked up. Along the way, he lost his driver's license. It expired. He couldn't afford to go back and get it registered. Other things were on his mind. Without a driver's license, without the money to find a place to live, it was hard to find stable employment. It was just a steady cycle. But it was essentially a litany of unmet social and legal needs. And here we were, our care team, seeking that quadruple aim and scratching our heads and saying, we're missing something. What we did was quite simple. We expanded the care team. So believe it or not, we decided to add one more person into that 10 by 10 foot room. Because why not? We found this gentleman, John. You can see there on the left-hand side of your screen. Mr. Martin, by the way, is on the far right, on the far left. Your right is John. John is a lawyer, a public interest lawyer who is actually working for a public interest law firm that was in an active lawsuit against the hospital I was working at. Now, pause for effect here. You can imagine some of the negotiations that it took to actually get that done, but it turns out when you made the obvious apparent, when people realized that unmet legal needs were causing Mr. Martin and hundreds of patients just like him to come in and out of the emergency department, and that the team member that I needed was a lawyer, the right thing was able to happen. But it was not a small feat. We ended up actually improving Mr. Martin's health remarkably by taking care of those traffic citations, by taking care of some of the outstanding issues he had with the DMV, by actually filing his disability benefits paperwork that he was eligible for but couldn't apply for on his own. By doing all these things, we got him $3,500 of annual income coming in monetary benefit. A monthly benefit, excuse me. It's a lot of money. When we looked at our cost-benefit analysis, we were spending about $500 of fixed costs for this program, and for every veteran, just like Mr. Martin, we were bringing in $3,500 of just direct economic benefits. That means less tickets, that means more disability benefits, that means more income and opportunity for Mr. Martin to get right again, get back into where he wanted to be. And that doesn't account for the financial benefit of the 24% reduction in emergency department use that happened among Mr. Martin and 140 veterans just like him. We did a happy dance. We achieved the quadruple aim. For those individuals, it is so apparent that when you hit the quadruple aim, we have to celebrate those moments, because if we don't, we forget it, and if we forget it, we can't replicate it. Now, what was it about what we did with Mr. Martin that actually was so dramatic? Well, certainly it was about bringing a lawyer into the clinic. It's not an unusual model. I think many of you are now familiar with what's called the medical-legal partnership. It's a concept in which lawyers go into healthcare settings and thereby help improve the quadruple aim for those in most need. 41 states have now implemented medical legal partnerships in over 300 healthcare systems. Beyond the medical legal partnership, though, something else happened. And what happened for us was that we just shifted our frame of thinking. We shifted what we expected of ourselves and what we expected of the system around us. And what we did essentially was to tell ourselves a new story. And the story was one I want to share with you today. It's a parable some of you have heard. In this parable, 3 friends come to a beautiful scene, a rushing river. That idyllic scene, though, is pierced by some tragedy. There are people in the water, screaming out for help. Children, adults, the elderly, all crying out for help, about to drown and fall over that waterfall. So the 3 friends do what each of us would do, right? You jump in the water. The first friend, who's a really strong swimmer, says, I'm going to find out who is at most risk of drowning, go to the waterfall's edge and rescue those in most need. The rest of us now have amassed along the riverbanks, and we celebrate and we applaud that person. We say, what else can we give you? What more resources can we give you? Do you need higher reimbursement rates? Over time, the second friend, who's there, also a strong swimmer, has a eureka moment and realizes, well, I can go a little further upstream here, and if I grab those branches along the banks of the river here, I can build a raft so I can usher more people to safety and prevent as many people from need of rescue by that downstream rescuer. Now, the rest of us have said, that's a brilliant idea. So we start moving up a little bit further to that raft builder, and we say, wow, that medical home you're building, interesting idea. What resources can we give you? Now, something's happening, though, to our 2 friends in the water. That downstream rescuer, that specialist, that comprehensivist, that raft builder, over time, as they continue to do this noble work, as they remain committed to this work, they realize something's happening to them. They're getting fatigued. We can see it in them. Their fatigue sometimes manifests as jaded cynicism. They say things like, and you can overhear them, they say things to people in the water, didn't someone teach you how to swim? Disparities, prejudices start manifesting out of this fatigue and this cynicism. But to their credit, and to the credit of all of us, they remain redoubled in their efforts. But they realize that their third friend is nowhere to be seen. So they look up, and we all look up, and we realize that third friend is way upstream, still in the water, still doing the work, saving lives as she's going. And they shout to her, where are you going? There are people here to save. And she shouts back, I know. I'm going to find out who or what is throwing these people in the water. In our care team for Mr. Martin, we had to actually incorporate specialists. We had to be ourselves a medical home so we could be a raft for Mr. Martin and patients just like him. But we also had to include on our team and in our system the third friend, the upstreamist. Someone whose job it was to routinely think about how the system and the teams within it were screening for and helping to address the social determinants of health, those upstream drivers that were leading to outcomes for Mr. Martin. I argue that if we're going to be able to move the needle forward, we have to take this opportunity, take this parable to acknowledge the obvious. Social factors account for up to 60% of health outcomes. Social circumstances, environmental exposures, and the behaviors they influence account for more than 5 times the impact on health outcomes than all the pills and the procedures that doctors and hospitals prescribe. It's not that physicians don't know this issue is important, right? In a survey in 2011, more than 1,000 physicians were surveyed, and 85% of them said that they knew that their patients' social needs were as important as their medical problems. That wasn't the problem. The problem was that only 1 in 5 of those physicians had any confidence in their ability to do something about it. That upstream efficacy gap among our healthcare workforce is one of the drivers for physician burnout, to a reduction in the number of happy dances that we're seeing in our healthcare workforce. A study at UCSF of over 500 primary care clinicians actually found that the strongest predictor of clinician burnout in those primary care practices was the lower perceptions that the physicians had about their clinic's ability to address those unmet social needs. If clinics didn't have the resources, such as dedicated staff or community programs or tools to help address patients' unmet social needs working in the community outside the clinic walls, physicians felt burned out. It's not just that this issue of the upstream efficacy gap is affecting providers. Payers are starting to pay attention as well. So a couple of years ago, an organization I started called Health Begins partnered with researchers at UCSF, and we actually researched what Medicaid managed care organizations were doing across the country. We talked to over 30 C-suite leaders in a whole range of Medicaid organizations, and we found that many of them were actually already making investments in social determinants. They were starting to work through their community benefits arms or through their care management funds or through their administrative dollars that they were putting together as seed funding. They were thinking of a variety of ways to be essentially to pilot work around housing or food insecurity and other issues. So we asked them why. And it's telling to listen to the responses because they framed their work around social determinants in the triple aim. One C-suite leader actually said, "We can't do the work we've been charged with and do it well unless we figure social determinants of health out." It's a quality issue. The COO actually said that we care about patient experience. We address social determinants because we want high levels of consumer engagement and high levels of consumer satisfaction, which is, quote unquote, the most important benchmark for me. How do upstream issues, in fact, address patient experience? Another said, we actually look at social determinants of health so we can try to decrease costs. They said, we don't go into this as if we're making grants. We go into this more as if we're making business investments. Payers, providers, and patients like Mr. Martin are all reflecting the fact that it's time for us, again, to acknowledge the obvious in this moment in history together. We have to acknowledge is that we are at a time right now when, I'm going to click forward. We must recognize that without better understanding the social determinants of health, without understanding how it impacts patients and providers and population health outcomes and even per capita costs, if we don't acknowledge the impact it's having right now, there's no way that we can get closer to the quadruple aim. It is not the only thing, but it is a necessary component of a strategy that tries to address our quadruple aim. And if you don't believe that, just ask Mr. Martin. So you might be feeling like a lot of folks in healthcare these days. Folks in the front line and folks in the C-suite. Folks in the payer community and folks in the patient community. All right, yes, I get it. Social determinants of health matter. I'm hearing these terms. Population health is important. Value is important. I'm not really sure exactly what that means yet, but I know they're important. The question is, how do we do this? So let's talk about how we do this right now, because it frankly is time for us to move into action. And the great news is we can learn from those who have been at the vanguard of this work for the past several years. Let's understand this by going into a case study. So I invite you all now into our collective hospital where Mr. Martin has come in for a hospital admission. An unfortunate event. We review his vital signs. Everything seems relatively stable. We review his case, a history of diabetes, somewhat uncontrolled. We review his medication adherence. It turns out he's taking his medications. We try to stabilize him. He's stabilized. And now we look at the lab results, and the lab results come back consistent with low blood sugar, hypoglycemia. A diabetic patient has been hospitalized in our hospital collectively with low blood sugar. Let's do a differential diagnosis. Let's identify the root cause of this together, shall we? If we're like many other hospitals in the country, we would start with a biological. Let's look at individual biological characteristics, or maybe look at the medications themselves. Perhaps there's something in the way that he was taking the medications, or something about the medicines or the physiology of his diabetes itself that could explain this. Well, we can move one step further beyond the biology and look at the behavioral, shall we? Let's look at the behavioral. Maybe it's how he's eating and how he's taking his medications and how he's exercising that may explain this. Let's look at lifestyle factors. Now, at this point, many of us will not be too out of sync with the mainstream. Many of us, actually, in healthcare are probably familiar with, one click forward. Oh, there we go, look at that. before I freak you guys out. This is an ancient Greek picture of omphaloskepsis, navel gazing. You probably thought there was something else going on there. Again, we're in the hospital. This is a clinical environment. We can be adults. If we lift our heads up past the biological and the behavioral and look upstream a little bit, we can understand that for Mr. Martin, this hospital admissions, this low blood sugar, hypoglycemic event was actually caused by a major pervasive root cause invading the entire country right now. It's food insecurity. Food insecurity affects 1 in 7 Americans. Food insecurity reflects the inability of a household to access food because of inadequate resources. It turns out the risk of diabetes in food insecure households is more than 3 times than those compared to food secure households. In other words, if you're food insecure and you live in a food insecure household, you have a higher risk of developing diabetes due to the roller coaster ride of physiology that happens when food comes and goes. When feast or famine hits your molecules, there's a way in which that itself may be triggering diabetes. It's a very potent issue to understand because, as an article in Health Affairs demonstrated a couple of years ago, lower-income adult diabetic patients had a 27% increased risk of a hospital admission at the end of a month compared to higher-income diabetics. Another study in Philadelphia looked at food insecurity, and the researchers used a USDA definition of food insecurity, and they found that more than half of their high utilizer patients, with hospitalization rates equating to at least 3 or more inpatient admissions within the last 12 months. When they looked at these high utilizers, they found that more than half of those patients were food insecure or marginally food insecure. This is remarkable. Just for a moment here, just let this sink in. Think about what QI team work is happening behind the scenes. Look at your data systems, talk to your IT folks, and ask them, wait, are we looking at this data? Chances are no. In this study in Philadelphia, 40% of those high utilizers responded that in the past 30 days, they worried that their food would run out. Another stat, 75% were unable to shop for food on their own, and nearly 60% were unable to prepare their own food. This is happening right now among our high utilizers, and we're investing so much in trying to think about how to address those high-cost, high needs, but we're doing so with omphaloskepsis. It's time for us to look upstream and I think understand another major scientific reason for what's happening here among us. And I think if we do so, we can actually think about using the resources we have amongst us. To achieve the quadruple aim, where do we start if we acknowledge that food insecurity is a driver for Mr. Martin, our patient? Well, the good news is we can use quality improvement. What I propose is that we essentially use a very simple get ready, get set, and go approach. Get ready essentially means let's get ready by assessing the maturity of our healthcare systems to address social determinants. We've done this for patient-centered medical homes. We've done this for electronic medical records. I can throw the acronyms out, but you know that every one of those business change transformations has been led by an assessment of readiness so that healthcare systems can take their pulse and understand their strengths and their weaknesses before they proceed in this new endeavor. So too must we address social determinants by taking at first a readiness assessment. We can look, for instance, at issues like the favorability of our environment. We can look at the degree of executive sponsorship. We can look at how well managed our social determinants interventions are. We can look at our financial readiness. There are at least 10 domains, if not more, that we can use, and there are tools that are out there, actually, that can easily allow us to look at the readiness of our systems. And if we do that, we can move on to the next stage, which is to get set. And by getting set, we can ask ourselves 2 basic questions. First, who are our healthcare-based upstreamists? Whose job is it going to be to address social determinants, screening, and integration within our healthcare system with the outside community? Because if we don't figure out which person is going to take on that job, then it's nobody's job. And the second question is, who are our upstream partners? And in the case of food insecurity, it's probably going to be a food bank. The question for us, though, is, in this hospital, with Mr. Martin in front of us, looking to us with a solution, we have to ask ourselves, can we name the upstream partner a food bank? Can we name the person who's there? Can we name the type of services they provide? Do we know their capacity? Can we get that level of precision in the same way we would expect our hospitals to understand the network of cardiologists or surgeons in the community? If you know that you can call the back office and know the number of the nurse to call to get a patient into that cardiology clinic, why shouldn't we have that same level of specificity and rigor when it comes to getting somebody into that food bank? It's time for more rigor, because without it, we're missing the quadruple aim. And as we get ready, and as we get set, identifying our upstream partners and our upstreamists inside our healthcare systems, we can apply basic quality improvement. So together, shall we actually put together a QI project? I nominate somebody in this audience here to be our QI project champion. Let's put the project charter together. Why don't we lay our aims out? A 30-30-30 plan, I say. Shall we, within the next 6 months, improve the way we screen for food insecurity by 30%? I think we can do that. You know why? Because right now it's 0. Shall we commit to improving provider confidence to address food insecurity? Can we improve our clinic capacity to address those issues? I think we can, because right now it is 0. Set reasonable goals, meet them, celebrate them, do your happy dances, right? Momentum, change management, we know this stuff. And can we also reduce hospital admissions within 18 months by at least 30% among those food insecure diabetic patients, just like Mr. Martin? Let's see if we can do it. And let's apply the same tools, the Plan, Do, Study, Act, and make sure that every time we do our iterations of those tests of change, that we're asking ourselves about whether we're moving upstream enough, if we're moving past the navel gazing. As we do so, I think we'll find that there's answers out there already. There's already a validated screening item that has been endorsed by the American Academy of Pediatrics. A tool similar to this one was actually just implemented by a hospital system in Ohio called Medica. Medica has been screening its patients recently. They incorporated it into their electronic medical record system, and that major EMR vendor, it's a vendor that has 4 letters in its name, starts with an E, ends with a C. They've actually decided to take those screening items and put them on the national database. So if you have that EMR vendor, you can actually go out and say, I want to pull down that screening item. We can ask our patients' families, how often are these following statements true? We can screen for this. And as we screen for it, we can actually go forward and pick a starting point for our intervention. There's levels of prevention we can start at. There are levels of intervention that we can start at. The most comfortable place for many of us in our hospital today is going to be taking care of Mr. Martin because he's hospitalized. He's that highest risk, tertiary prevention requiring patient. So let's work on that level first. It's a reasonable place to start, but we should acknowledge that as we build our efficacy to address upstream issues, we as a healthcare system can start doing things at a secondary prevention level. We can even look at primary prevention levels to address diabetes and food insecurity. But we'll start where we know we can start because we want to hit that quality improvement target. And as we do so, we can put in place simple solutions. Just like that hospital system in Ohio, we can put in place a hospital-based food pharmacy, and it looks a lot like a pantry. And we can prescribe this food in this pantry, just like the folks at Medica in Ohio are doing. With a physician referral, we can offer them 2 to 3 days worth of food per visit. With monthly follow-up for 6 months, we can put in place nutritional counseling and access to healthy recipes, connection to community resources. We can do this because it's been done, and we just have to copy, paste, iterate, learn. We can do this. And as we do this, we'll find that when we move forward through all of our systems, what we're coming across is a new way of looking at our healthcare system, a way of looking at the world that I call upstream medicine. It's something that lives at the intersection of health systems improvement, in which we look at performance management and quality improvement methodologies, at practice transformation efforts and health reform efforts, including those moving towards value. We can take that body of energy and those resources, which we have more than our social service peers. We can marshal those resources and bring in our population medicine folks, like those who work in community-oriented primary care or social medicine or preventative medicine. And we can bring together that next circle, the folks who work on the social determinants of health far outside of medical care, those in public health and transportation, public interest law firms, even if they're suing you. We can do those things and at the intersection find that what we can move forward on is upstream medicine, a concept that is pretty common sense. It's the love child of Jack Geiger and Don Berwick. I'll move on. For those who didn't get that, turn to your neighbor who did, and you'll see their grimace. The point is that we have the ability to stand on the shoulders of giants in each of those fields. And all we need to do is actually start to get ready. get set, and go. Because if we do so, we can find out that by moving upstream, we can help achieve that quadruple aim. We can achieve better outcomes for our patients, better experience of care, just like Mr. Martin. We can start to lower per-person costs, reduce those ER visits, and we can have finally, a healthcare system in which you walk into a doctor's office and just out of the corner of your eye, you see the doctor, the nurse, the care manager, a social worker, and maybe even a lawyer doing a happy dance. Thank you.